Hi, welcome. So this is a little bit of a freebie from me on some recent thoughts I've been having on scoliosis, and I'm sure many people have come up with similar thoughts, but anyway, I just thought that I'd share some perspectives that had occurred to me, and maybe to give some alternative insights as to what might be going on into scoliosis generation. Just in terms of finding out information about where you can get more of my material if you're interested, there are these two websites here, and you'll find lots of stuff there which might be of value. So in terms of scoliosis then, how does this arise? There's quite a lot of theories. And one of the main theories is about how the ribs move and twist and how uneven pressure is imparted on the vertebral bodies. And so the growth plates of the bones begin to remodel. In this talk, I'm discussing idiopathic scolioses, not congenital hemivertebra or other such etiologies of scoliosis. So if you have a vertebra with two transverse processes and ribs that join into those transverse processes and sides of the bodies, if the pressure exerted from the trunk wall all the way around, encompassing the ribs and intercostals and abdominals, etc. If that trunk wall pressure, as it accumulates where the ribs attach onto the sides of the TPs and bodies, if that pressure is equal, then of course there will be bilaterally symmetrical pressure onto the vertebral unit, and it will not rotate. But the minute that you get uneven trunk pressure and uneven dynamics coming onto the TP side of the bodies, then you will start to get pressure exerted. And as you press onto one side unevenly, then you will begin to get this rotation. So it's a really interesting and dynamic action whereby the body wall, the trunk walls, are the generating foci for the scoliotic initiation because of the influence of the pressures onto either rib as it attaches onto the vertebra. So again, if you copy and paste these article titles into Google, you'll be able to get onto the an example of the article which discusses that dynamic. Now, there's another idea about scoliosis genesis, and that being in relation to retained primitive reflexes. And again, this is to do with asymmetric trunk muscle tone. In these particular instances, the spinal galant reflexes thought to be involved. So it's not unassociated with the types of theory that we were just mentioning, but it's one specifically related to if the retained reflexes are there, then you won't get the appropriate ventral posterior trunk muscle relationships. You won't get coordinated action, and you'll get adverse or inappropriate timed resting motor tone of some of your spinal or axial muscular components. And so when you start to get this sort of dynamic associated with the lack of integrated motor patterning control, which seems to be prevalent in children whom have retained primitive reflexes, then this rotation of the trunk appears to be quite common in them, and so of course will then link into the dynamics of the scoliosis generation. So obviously one dynamic for them would be the understanding of which reflexes are retained, how you can unlock those. Is it just the spinal galant? Usually there's more other reflexes that you can then bring into play. And so you can try to do some manual approaches to care, some osteopathic techniques and some reflex integration exercises, which may well help to restore that appropriate motor patterning balance. Now, there are a variety of osteopathic theories, and I am going to come back to these in a little bit more detail. But for example, here's one little article that you can copy and paste the title of, stick it into Google, and looking at whether you have progressive infantile scoliosis and can it be managed with osteopathic manipulative treatment. So this is a small population set, so it's just a limited profile. So it's not generalizable across the whole population of people with scoliosis. And the idea is that you would have something which starts in infancy and persists through, but that if you do some osteopathic myofascial releases, etc., it may well help to manage at that time. I think that when osteopaths put their hands on babies, they do all sorts of things. And as we'll discuss, I don't think it's all to do with the involuntary mechanism theories. And I think there's a whole range of things, for example, in infants, whereby we're looking at sensory input from skin and myofascial receptors, whereby we're engaging sensorially into motor patterning coordination input. And so it may well be that we are helping the infants to manage their maybe asymmetrical motor sensory input, as opposed to having the improvement if there is a generalizable improvement with the osteopathic manipulative treatment. I think it may well come through this motor sensory input rather than the involuntary mechanism dural tension and dural tube down the vertebral column scenario, but we'll come back to that. How do you actually manage any of these ideas? There are obviously other etiological theories about scoliosis, but these are just a couple for the moment. But how do you deal with it? So again, apart from say like the osteopathic unwinding that was mentioned in this little article just here, there is a lot of work done within the physiotherapy field with the Schroth method. So there's endless YouTube videos that you can actually watch. So again, copy and paste that number, and that begins to get you into this dynamic. So of course they would advocate that you only have your exercise routines and stretch routines prescribed for you in a controlled manner from the practitioner trained in the method, because essentially if you have a mixed curve with some convex, some concave, all the way down, all of those the extent, length, angle, amount, and so on, and combination of curves is going to be unique to the individual. So of course what you don't want to do is do an exercise to, for example, side bend to the left, for argument's sake, to open out this curve, because if you do that inappropriately or to the wrong zones of the spine, of course if you side bend left, you may well exaggerate an adjacent curve. So the idea is that your left side bending, which would open out this curve, is only done to this section of the cord and only done to the amount that it opens this without interfering and compounding the adjacent curves, for example. So there are ways that you can help to do that, and some people use elastic straps or barriers and holding to enable the person to get the idea of which part they're supposed to be working on in which way. And so this, again, it's quite an involved dynamic, but Schroth method seems to have quite a good outcome, or at least is strongly contributory to managing scoliosis for a number of patients, but it does require quite focused work. It has to have high compliance, and it has to have high accuracy, and so the patient engagement and the family engagement with that as a management process can be quite involved anyway. But Schroth method, if you're not aware of it, that's quite interesting. So let's have a little bit more of a look into the dip into these rotational dynamics. Now, if you're into classical osteopathy, you've got this idea of two triangles, upper triangle, lower triangle, and these two triangles which control the orientation of the upper body, head and neck onto the main trunk, etc. They would have a meeting point just where you actually have the main axis of rotation in your thoracic cage as a whole, which is approximately opposite to D4, top of the back of the heart, that sort of zone of the mediastinum. This is essentially what we're talking about is the meeting point of these two triangles, but in general terms, when the thoracic cage rotates around itself, it will do so about an axis which is just ventral to the upper dorsal spine. So it's usually centered around the ventral part of D4. And so as you do that, as you rotate, I've got a little schematic here, a little bit of a cross section. So here we've got a little vertebra. Here you've got a rib, obviously coming into the cartilages, sternum, the other cartilage, and the rib again, all the way back to the other side. These two little circles here are indicative of the sympathetic chain ganglia, which sit just in front of the rib heads. Now, when people think about rib movements, you think pump, handle, bucket, handle, pump, handle, bucket, handle. Now, the movements which I'm just talking about at the moment, nothing to do with that. So these are accessory movements that you will get. So instead of pump, handle, bucket, handle, pump, handle, bucket, handle, you'll now get a different rotatory movement. So this is an accessory movement. So to understand that, let's have a little bit of a think. Looking at this big arrow here, if I turn myself to the right in this rotation, then obviously this rib comes round and around and around and exerts the pressure here, as indicated by this little arrow, onto the side of the vertebra. Now, if you actually just imagined a series of cogs, such that here we have the rib moving, and here it comes into contact with the vertebra. So as we see this rib following round from the rotation at the front, then we'll see that that induces an initial tiny bit of rotation into the vertebra. So like a bit of a taking up of slack, costotransverse, costovertebral articulation, a little bit of slack there. But of course, as the vertebra now moves in this direction, then it's inducing a different movement onto the other rib. So now with the vertebra being this hand and the other rib here, as the first rib brought rotation into the vertebra, this vertebra is now bringing an opposite rotation to this remaining rib. So you would have this rib becoming posterior, if you like, or rotating in the, or moving in a opposite direction to its fellow rib. And of course, it all follows this overall global movement of the thorax to the side, and this is what's going to be happening at the rib head. So you'll get this accessory anterior and posterior small guide of the rib head, which again also makes it dynamize those sympathetic chain ganglia. Now, in order to start to get some of this rotation going, as we understand the anatomy within the thoracic cage, then what we see is that we've got a series of sliding surfaces formed by the two pleural interfaces and the pericardial interface. As we know, our parietal pleura is attached to the inside surface of the ribs and intercostals all the way around. The parietal pleura then reflects through here and lies adjacent to the outside aspect of the pericardium. Now, the pericardium itself, as we know, that's anchored down to the inner aspect of the sternum, and it also has this other interface through to the parietal pleura onto the other side, and then that other parietal pleura again is attached to the inner surface of that side of the rib cage. So we've got our parietal pleural bag here, and our pericardial bag here, and our other parietal pleural bag here, all attached to the inside surface of the rib cage. So as the person rotates as a whole, that parietal pleura and all those pericardial bags have no choice but to start to deviate with that global thoracic cage or body wall movement. Because the pleura and the pericardium is a double layered arrangement, inside the pleural sac or bag, the parietal pleural sac, then of course you'll get your visceral pleura containing the lungs. So where you have this small gap between the visceral and parietal pleuras, and between the fibrous pericardium and the inner myocardial layers, you will get this sliding surface. So you'll have pericardial fluid here, you'll have pleural fluid here, and pleural fluid here. And so that means that as you have trunk rotation, you have a small degree of freedom such that as the trunk rotates, then the inner visceral bag can have a slight freedom of movement, irrespective of what the main body wall or outer parietal pleura or pericardial sac is doing. But obviously, if you get any degree of irritability, restriction, stickiness, if you like, or inflammatory dynamics or adhesive components within these pleural or pericardial sliding surfaces, of course, that can begin to tether, if you like, onto or between the pleural layers and lead to some resistance of movement into rotation. So you may not get the full expression of these little accessory movements. So a whole variety of things may actually contribute to this asymmetrical motor tone. So whereas before it's asymmetrical motor tone, rather giving the adverse pressures onto the rib heads and thereby scoliotic generation, it may also be all sorts of things such as legacies of vascular changes, legacies of respiratory conditions, which have left these pleural sliding interfaces, or even the contractility and compliance of the underlying organ itself. They may have now accumulated a little bit of resistance, which is then contributing to asymmetrical global overall thoracic cage dynamics. So there may well be something in terms of the inner aspects of the thoracic cage and the contents therein, which has a secondary influence on the generation of scoliosis. So this may well be some of the relationship of the overall scoliosis dynamics, something within the body cavities and the visceral myofascial dynamics within the cavities. Now, just another little bit of a view. Obviously, there's a lot of talk, huge amounts of literature about scoliosis generation, dental occlusion, TMJ alignment, bites, etc. So there's masses of information about facial asymmetries. So with all of this dental information, they're obviously looking at global posture and alignment with respect to the horizontal plane. Now, if you actually look at a lot of the, there's endless x-rays similar to this one on Google Images about scoliosis. Now, one of the things that I'm quite interested in is if we look right down at the bottom here at the two acetabulae. So you've got, so looking at this horizontal plane information and looking at this acetabular dynamic. So with a bit of quibbling, that's relatively level. If we look all the way up at the top here, that's relatively level. The actual amount of rotation that we can see, if we look at how all the TPs are lined up within the cervical spine, what we can see is that much of the cervical vertebrae alignment is neutrally placed, so in a reasonably normal position. If we come to look back in the lumbar region, this is not so even, but we get more if you like, forward-facing dynamics of the low lumbar spine and sacrum than we do compared to the whole of the dorsal spine. So the dorsal spine itself is particularly affected in this. And one of the things I'm really curious about is if, for example, the osteopathic theory about condylar asymmetry, condylar pressure causing a torsion through there, which whistles down the dural tube and spinal column, one would expect to see some degree of involvement drifting through the whole spinal column, not just focused within the dorsal zone. And even if, as that spiraling continued, then the whole body reshifted to try to accommodate that overall spiral, I would expect to see more distortion and unevenness or compensation, perhaps within the cervical region. But often these zones seem relatively unaffected in terms of spinal dynamics. But when we actually start to pick into it, actually some of the distortions are actually within the face, not so much the condylar parts or the cranial base, if you like. It's actually within the facial skeleton. Now, the facial skeleton, as we know, is not attached to the dura, so it's not part of that reciprocal dentin membrane absolutely directly. It is obviously influenced by it. But the facial dynamics, there's all sorts of things which actually attach through this facial skeleton, which may well bear fruit for some other ideas. But the structures which hang off the face are obviously in relation to sort of pterygoids and things to do with the jaw, but it's also tongue, it's mandible, it's infrahyoid, suprahyoid musculature, it's the pharyngeal fascia, it's this whole visceral, tracheal, pharyngeal dynamic down to the esophagus, into the mediastinum, down through over the cardiac and hilum of the lung structures. And so this column is not absolutely following just what the dural sleeve is doing. It's got its own pattern. And it seems to be that the amount of facial distortion is quite strongly correlated with the actual scoliotic patterning. So I found that was quite an interesting perspective as one begins to unpick it. So that actually the driving force for restoration of this alignment through the core, which may or may not also have bearing with this mediastinal rotatory pattern that we were talking about earlier, is what's actually happening in the face, the facial bones, the facial tissues and so on. If we actually then look a little bit down at the lower part of the body, we actually start to focus right down on the trunk walls where they come to the iliac crests, and what's actually happening at that bottom end. We have quite an interesting thing with respect to the iliac bone and its hypophysis, so along the top of the iliac crest, and what's going on there, because obviously if the trunk motor tone is asymmetrical, you get a different traction apophysis along either iliac crest. So with the developing bone in this adolescent period, asymmetrical motor tone engages differently the two parts of the ilium. Now, when we actually look at the iliac crest in X-ray, what we can often see, of course, is the this sign here with these two little arrows, whereby you just get slight difference in traction because of the muscular pull and the extent to which this apophysitis is occurring along the line of the crest, how lateral it spreads, gives us an indication which is closely correlated to the severity and the overall management implications. So looking at this trunk motor tone as it inserts onto the bottom, again gives us this idea of the pelvic dynamics, and looking at the irritability of these tissues, I think is quite interesting. So in fact, one of the things that you could do is to think about working all along that iliac crest, getting your thumbs right along there, looking at the, if you like, trigger points. I know that's a dirty word, but any of these tender points, muscular irritabilities, periosteal irritations on periosteal signaling across there, really get yourself into those really tender zones, and that may well have a proprioceptive sensory afferent signaling through into the trunk motor system, and may well help to at least give some initiation into changing that motor patterning. So obviously that again helps to reinforce the trunk motor dynamics in amongst this whole global story. So there is, of course, now then this dynamic of the, if you like, an osteopathic contribution to this story about it being in relation to the birth process. So obviously Seguth and Nelson, etc., have done some work on their palpatory diagnosis of plagiocephaly and looking at correlations between birth strain patterns at the SBS and the sphenobasilar synchondrosis and the actual alignment or presentation into the birth pattern. And so they felt that there was quite a correlation. So from my perspective, though, I think that there's two comments that I'd like to make with regard to this, which doesn't say anything about what they found on their findings. So I'm not criticizing those findings, but what I am suggesting is that many people's birth processes are not as simple as just when you go into birth lined up a certain way, and then when you eventually work your way through. From the infant's perspective, you're often exposed to a whole variety of other moulding strains, intraosseous strains, muscular irritabilities, and pain generators and pain foci and inflammatory dynamics, if the birth process has been in any way stressful onto the tissues, and that may well compound, differ, or add into all of this supposed birth stress strain patterning. One of the things also, I think, is that when one is born, for a whole variety of reasons, you might have a head preferencing, but it's the head preferencing itself when you come to lie as the baby is laying down, that as you settle that soft head down, and because of the dynamics of plagiocephaly, development of deformational plagiocephaly, not the other types, it is this softness and this load bearing which helps to splay. And of course, if you have even the slightest asymmetry of pressure onto the posterior part of the baby's head as it's lying on its back, then of course you will start to get splaying, and the exact splaying that will then tend to induce are different types of shearing, which can accumulate at the level of the SBS as well. So you can get, I think, a dynamic which doesn't actually have to have been generated in the birth process. It can then simply be a handling or positioning of the infant subsequent to the birth, which then creates a moulded patterning. And it's that moulded patterning which may also be able to be detected. So it's a handling consequence, as if like a parental etiology, rather than a birth process dynamic. So I'm, if you like, slightly cautious of ascribing it to the birth as opposed to post-birth handling. But anyway, obviously there's a overall relationship, but I don't think that it's this whole, it's not the real main story of scoliotic generation. So obviously, but though there's lots of people who make references to the intraosseous strain patterns, where the birth process can look and place different sensory and mechanical stresses into all of the different subparts of the basiocciput, what am I saying? Basiocciput, around the foramen magnum, where the condylar parts are, and so on. And because they have different ossification centres, you can get stress and strain within these bones, which of course is always going to be helpful to unwind. So whether it's come secondary or is a primary factor, it's also obviously something that you can work on. But I'm just not sure it's the generator of most of the scoliotic problems that are seen. So, you know, if, as I said, we were to try to get this sphenobasilar junction, this torsion at the condylar parts, if, as most babies are born in the left occiput anterior dynamic, because of that, we would expect a quite significant number of infants with a left occiput anterior presentation with a certain strain pattern of the SPS. They would have a high correlation of that strain, and as you strain or put that strain at the cervical level, because if you rotate one part of any of a curved column, then you will start to get spiraling all the way through. So you would expect the scolioses, if they're present, to all follow the same pattern, same direction. And so on. So if it's to do with birth strain, and as most birth strains are left occiput anterior, then the scoliotic dynamic would be no different from male babies or female babies. And as your scoliosis continues to generate, there'd be no different between whether it's left-sided or right-sided in its predominant curve pattern. But actually, that's just not what's found. There are quite a number of age and gender differences between how scoliosis presents. So, for example, most adolescent scolioses, they're more frequent in girls, as we'll come back to whether it's estrogen related, but it's right-sided in 90% of the cases. So when scoliosis comes on in the adolescent age group, it's mostly girls that are affected, and it's mostly right-sided. And though when we look at babies, so infantile idiopathic scoliosis, it's actually much more frequent in boys, and it's left-sided. So, you know, it's a very general thing. Baby boys get scoliosis, but it's to the left, and adolescent girls get scoliosis, but it's to the right. So it can't possibly be that there is this dynamic of just this cranial base pattern squirreling up the dural tube and spinal column as a consistent factor, because it just doesn't fit what actually seems to happen in real life. So there has to be something else which is linking adolescent girls and infant boys as to what else might be going on, as to why we would then also get a laterality difference, as well as a age difference, timing issue difference, and gender differences. So what could be going on with all of these things? So I think that there's all sorts of other interesting things. Now, to some degree, there is a rotational pattern in all infants to the left, just a little bit, but they don't. It's mostly the boys that then slip into the scoliotic dynamic, but girls don't tend to at that age. So, but you know, that there's some suggestions that generally speaking, infants are going to go to the left, but infants will, adolescents going to the right. It's not normal. So all of us, without any scoliosis, if we looked hard, we'd have this little bit of, in adolescence, this, or juvenile dynamics, this slight right inclination, whereas infants have a common left inclination. But it's what else could be tipping. So what causes that lateral inclination as a normal tendency, but what then further tips it into the increased lateral displacement, such that the scoliosis then becomes self-propelling and maintaining. So I think there's actually quite a proposal relating to the weight of the organs, this core fascial link. So from the facial skeleton, the superior pharyngeal dynamic down through the face, down through the TMJ jaw, into the tongue dynamics, mylohyoid, into the trachea, etc., down the cervical fascia, into the mediastinum, around the heart, onto central tendon, and then through the subdiaphragmatic organs with liver, etc., and then all the way down into the abdomen. So it's that core link of fascia, the visceral fascial core link, which is buried down within the center line of the body cavities, and not the dual tube torsion, not that sleeve of tissues, which seems to be, for me, the interesting dynamic here. Because with a different loading here, literally the heaviness of the organs, whether as they're pulling down, and whether these organs themselves are anchored more to the left or more to the right, or more midline or more lateral, as the children grow. I think that load bearing, if you like, and the vertical pressures onto the body cavity as a whole may well be bringing us some rotatory inclinations. So it does seem to be that actually the positionings relatively and the dynamics of whether they're in the midline compared to the trunk alignment, that does seem to change between infancy and childhood. So for example, when you look at normal imaging, for example, what are the normal borders of the liver in an infant as opposed to later on in your sort of school age kids. If you actually look then radiographically at the outline, you can see that the liver will protrude progressively less underneath the costal margin. So with our costal margin here, infants have a low-lying liver, which gradually recedes such that the rib cage, if you like, grows over the liver border, covering it up. So you actually get a different displacement where the rib cage is expanding over. The spleen on the other side also keeps growing, and it's going to take up more of underneath of the left dome of the diaphragm. So again, the normal splenic size in infants and its lateral placement and size, volume and heaviness, because of course don't forget the spleen is a very fluid-filled organ, and so therefore not without weight. That changes. Also then with heart position, there is quite an interesting look at to see where the long axis of the heart lies, either in infants or in adults. And I think again that the substantialness of the large muscular mass of the heart and its relative incompressibility, the fluid dynamics there means that it is quite a structural component within the global chest alignment, especially in infants. And so I think that that scoliosis concavity is in fact probably related to a whole host of these organ loading dynamics within the body cavity, causing the trunk walls to be slightly differently loaded and therefore asymmetrical with respect to the pressure onto the spinal vertebral column, and therefore giving an inclination mildly to one side or to the other, as is found as sort of routine. And so here's a little bit, for example, about the heart. If you look at the infant, and then you look at the school-age child, and then you look at the adult, we can see that actually if we look at the heart valve positions, so we've got all these little numbers here and these little circles indicating the landmarks for listening to all the heart valves. In the infant, we can see that actually it's most of the heart takes up a much wider proportion of the infant chest. So proportionally it's huge in relation to the total diameter of the infant chest. It's also much broader transversely than it is vertically. So there's quite a different loading for the infant heart onto the immature rib cage. Now, as children start to grow, this middle picture, then you start to get a relative narrowing of the transverse position of the heart, or transverse extent of the heart, and a gradual lengthening. So as the torso begins to expand, clearly the heart is now going to be exposed to different stressors, and so you'll begin to get an evening out of the amount of lateral space taken up, and or transverse space taken up, and the vertical space. Whereas, of course, then when we get into the adult dynamics, we now have a much narrower heart and a much longer sort of dynamic, so that the overall load, shape, the heaviness, if you like, the weight of the heart in the adult chest is much more centrally placed, much more vertically aligned in our cavity, whereas the infant heart much more transversely played and much closer to the edges and confines of the thorax. So that literal loading, I'm sure, helps to explain some of this difference in laterality. But there's one other thing that's interesting with respect to what links adolescent girls and infant boys. And so this is the effects of estrogen on the skeleton. This is the, if you like, the part of the commentary whereby there needs to be a little bit more data searched for. But obviously both boy skeletons, boy babies and girl babies are equally exposed or have exposed to estrogen with respect to the pregnancy, birth process, breastfeeding and so on. Obviously, boys use estrogen differently in their bodies compared to girls, but it may well be that the infant skeleton has a different relationship to the the bony structure, the metabolic dynamics of bone within boys may respond differently to estrogen at this age compared to girls. And so in fact it may well be that perhaps infant skeletons, boy infant skeletons, are perhaps softer because they are less they're not going to, if you like, plan to use estrogen ongoingly in their life in the same way as girls. So it may well be that their skeleton responds differently to this birth-related sort of dynamic of estrogen. Now, girls, obviously, as you then get to puberty, they have a larger changes in their estrogen dynamics, which of course then boys in puberty don't have. So in fact, these girls will then get a large flush at this adolescent period, and it may well be that at that point the estrogen dynamic changes affect them more skeletally and structurally in their metabolic dynamics and their strength integrity of the bones, and an adolescent period compared to when they were infant girls, because their skeletons may well be able to accommodate the estrogen levels at that point better than boys. But when it comes to being an adolescent girl, because of the then extra very particular loading and change of the menstrual cycle hormones, it may well be that that's when they get this softening of the bones, which if they have any lateral inclinations within them, any motor trunk asymmetries, may well be what, as the skeleton softens, it starts to splay and shoot off into some sort of scoliotic thing. So that's the theory that I'm giving some thought to currently. So it'd be really interesting to get some feedback on that. And of course, there are, as I say, lots of other types of influences in scoliosis, and I'll just pick up on one generally, that being of the vestibular system. So again, I don't know how vestibular development works with respect to gender-based and age-based dynamics with respect to scoliotic scoliotic development. But certainly the vestibular system, as it is developing, is very strongly linked to the axial and spinal motor tone patterning. So when you spin a child, they automatically straighten up, or they should do, because they should get this incremental increase and recruitment of the local spinal erector spinae muscles, such that it then braces you vertically to stiffen the spinal axial component under a spin dynamic. And so when you have different dynamics going on within your vestibular system, if you have this problems with vestibular asymmetries, or if you have vestibular integration or sensory impairment dynamics, that there is quite a bit of thought about the fact that the generation of scoliosis comes from this vestibular dynamic, as opposed to the other dynamics that we've talked about. But either which way, whether we're beginning to look at it, there's probably some truth in all of these, some blended dynamics, because in fact the vibration sense in the spinal column, that seems to be linking maybe within the spinal gland, and also that then linking into the vestibular system to ensure symmetry in the motor tone of the axial skeleton, and that the vibration signaling and the interosseous strain components coupled with the visceral weight and relative sizes, if there is a motor asymmetry, that may well lead to this dynamic that's actually sort of operating because of the differences of sex hormones and so on. So who knows, but that's just a little bit of a commentary. I hope you've enjoyed it, and thank you for listening.